Hello and welcome back. So, I'll be discussing an approach to chronic focal consolidation. This is part of our approach to chronic dyspnea, and today we will just be deriving the diagnostic framework. And in the subsequent videos, we'll discuss some of the topics that are alluded to in this particular talk, as well as go into the imaging details of these topics. So I'll start with the case. So our case is a 56-year-old lady. She's a known case. She has no known comorbidities and has no history of substance use or abuse. Who's now presented with joint pains for the last 2 months, which were gradual in onset, progressively irritative, asymmetric, mixed, large plus small joint, inflammatory, polyarthritis with swelling all around the involved joints and EMS of around 2 hours, involving the left ankle initially, followed by the left more than the right wrist, followed by the left knee, then the right, second, and third metacarpophalangeal joints, as well as the proximal interphalangeal joints. Along with this, she had shortness of breath. She had gradual onset, persistent, progressive, exertional shortness of breath without any significant postural or diurnal variation. But this was associated with chest pain for the last month, which was gradual in onset, persistent, non-progressive, moderate to severe, sharp catching pain in the left lower chest, aggravated by deep breaths and relieved on lying down to the left side. So from our first discussion in the approach to chronic dyspnea, it becomes quite obvious that since shortness of breath is the main complaint, this is likely a alveolar pathology, okay, more than an interstitial pathology, okay, or pulmonary hypertension. Since there is no predominant postural variation, and unilateral pleural pathology is ruled out. And among alveolar pathologies, we'll see what could be the consideration. But importantly, there is a pleuritic chest pain on the left side, indicating that the pathology is more likely to be alveolar, because interstitial and pulmonary vascular pathologies usually don't extend into the pleura, and secondarily is involving the pleura. Okay, so that becomes quite clear even from history. And okay, so this is our pathology. It is an alveolar pathology which is secondarily extending to involve our same-sided pleura. Obviously, it could be a pulmonary vascular pathology if it was acute shortness of breath. That is, it could be pulmonary embolism, but pulmonary embolism obviously will usually not present with chest pain and shortness of breath for such a prolonged period. There is a history of being diagnosed as community-acquired pneumonia when she was treated elsewhere, and she was given 7 days of IV piperacillin tazobactam. No significant improvement in symptoms occurred afterwards. On examination, she has no pallor, icterus, cyanosis, or clubbing. Head to foot examination we'll discuss in detail later. The vitals show an elevated respiratory rate. Other examination points are normal. The examination of the respiratory system was significant in that the trachea was central and there were bilateral vesicular breath sounds, but there were left more than right subscapular, infraaxillary, tubular bronchial breath sounds with no other added sounds. Okay, so on the examination of the musculoskeletal system, there were 5 tender joints and 5 swollen joints. There was bilateral wrist, right second plus third metacarpophalangeal joints, and the right first PAP joint. So, this is a discussion on chronic shortness of breath. For now, we will not be discussing the approach to joint pain. I will be, however, going into it in another video as soon as possible. So basic investigations in this patient showed that the CBC had homocytic normochronic anemia and some thrombocytosis. There was neutrophilic leukocytosis, but there were no other abnormalities. The KFT show was normal except for an elevated serum uric acid level. The LFT showed the enzymes were less than 1 times the upper normal limit. They were not elevated. The albumin hemoglobin ratio was normal, and there was no hyperbilirubinemia. The urine RM was not very significant, epithelial cells of 4 to 6 per high power field, and the albumin, there was no urinary albumin present. The chest X-ray was not available. However, the old X-ray, after being evaluated elsewhere, the patient was told that she had some abnormality on the previous X-ray. The ECG showed normal sinus rhythm and no other abnormalities. PFT, the patient was not able to perform a PFT because of a shortness of breath. And this is the CT of the thorax uh, that we have. So this is an actual patient of mine in recent times. So as you can see, there is a area of increased attenuation, okay, involving the left lower lobe, and a little bit of similar increased attenuation, patchy attenuation in other areas, okay, in the left lingual lobe, left up, the upper segments of the left lower lobe, and so to a lesser extent on the other side as well. Okay, so what does this indicate? So this probably indicates that this is a consolidation. Why am I calling it a consolidation? Because the opacity is so opaque that you cannot see the vascular markings within the opacity. Now, it is not a homogeneous consolidation. There are areas of actual sparing in between the consolidation, and so that is something that we go into detail into details later, the details of later. And there are areas also of ground glass opacity surrounding the consolidation. So there is a little bit of central lobular nodulosis also, if you can peel your eyes into it. So for now we'll just call this a consolidation. Okay, so how do we analyze this? So first of all, what is a consolidation? So consolidation is, this is the normal architecture of the pulmonary parenchyma. So this is your alveoli, this is the capillary right next to the alveoli, and there's some interstitium in between. When you have a consolidation, basically the air spaces, that is the alveoli, are opacified. Okay, so the question essentially becomes, what is obliterating the alveolar lumen? Okay, and by an extension of that question becomes, what is pneumonia? So clinically, at least, often a term called non-resolving pneumonia is used. So this term is actually, it's meant to denote patients who have not responded normally, quote unquote, despite correct empirical antibiotic therapy for community acquired pneumonia. Okay, so our patient basically. And what is the correct response? So the normal response for a community acquired pneumonia, bacterial pneumonia, is that within 1 day there is a decrease in the patient's apprehension. The second, by day 2 there is an improvement in BP if the patient was in shock. By 1 to 3 there is a significant reduction in the CRP. This is high sensitivity CRP. By day 3 to 4 there is a reduction in the total counts, and by around day 10 you get to start to have a resolution in the pulmonary auscultation findings and the cough, notably not radiological findings. Okay, whereas the abnormal response would be if you don't have any of these things till day 5, and that we call a non-resolving or a non-responding pneumonia initially, and then by day 10 to 14 we start calling it a non-resolving pneumonia. Okay, now the issue is, the non-resolving pneumonia moniker is used slightly vaguely. Okay, and I prefer to use the term chronic consolidation. Okay, so the issue is that there are a lot of things in the baseline presentation of a pneumonia, of a consolidation, that can give you an idea regarding the likely underlying etiology. So not all pneumonia should be put into the bucket of community acquired pneumonia and not thought about again. So I'll use the term chronic consolidation, and let's see what chronic means. So chronic consolidation basically means a consolidation that has lasted for more than equal to 4 weeks. This may be based on the patient's symptomatology, or it may be based on the um, the imaging findings, which are that suggest a little bit of chronicity, some fibroatelectasis, some cavitatory changes that would take slightly longer than 4 weeks to likely happen. Now, such a pneumonia we've discussed can only be focal or multifocal, because anything that is so diffuse and so chronic would be likely not compatible with normal survival. Now, so how do I approach a patient with chronic focal consolidation, that like my patient that I discussed in the beginning of the talk? So one is, first we talk what when we have a quote unquote non-resolving pneumonia, I do an imaging. Okay, so we've done an imaging in this case already, and we find either a focal plus chronic focal or multifocal chronic consolidation, and or we find a nodule. Okay, and we know now that something is replacing air within the alveoli. So what could this something be? It could be a non-cellular material, it could be a cellular material. Okay, and when it is a non-cellular material, particularly within the alveoli, these are the possibilities. So the alveoli, like I have discussed in previous discussions, the interstitium of the lung has negative pressure in it, so usually the alveoli are dry. Okay, and that can get perturbed, so you could have pulmonary edema. The second thing is that you could have proteinaceous material getting deposited in the alveoli. This could be of true of any tissue, but in the case of the alveoli, it could be amyloid. Okay, then you could have pulmonary surfactant proteins getting accumulated there, and that we call pulmonary alveolar proteinosis. Finally, we could have this is not strictly non-cellular, but since the name indicates there's a lot of lipid accumulation, I've put it under this bucket. So you could have accumulation of lipid-laden macrophages within the alveolar lumen, and that is an entity called lipoid pneumonia, which actually is very easy to pick up on imaging because lipid obviously has a lower attenuation than other materials that I'm talking about right now. So this has a very specific imaging finding. And lipoid pneumonia is something that you can suspect it is a possibility in certain situations, provided you know that there is an entity of the sort. Among the cellular materials that may infiltrate into the alveolus, you can conceptually divide it into four buckets. So we have non-malignant and malignant. Obviously, any cell can be malignant or non-malignant, and we have cells that are proliferating in situ, that is cells that are originating from the lung or are normally located within some compartment of the lung, and there could be cells that are normally not located in significant numbers within the lung, so cells that are infiltrating into the lung. So since this is a slightly long diagnostic framework, I'll be giving numbers to each of these categories. Okay, so one would be non-malignant in situ cell proliferation, two would be malignant in situ cell proliferation, three would be non-malignant cellular infiltration into the lung, and four would be malignant cellular infiltration, okay, into the lung. So I hope that is clear. So let's start about consolidation due to in situ cellular proliferation. So again, non-malignant in situ proliferation would be due to either proliferation of fibroblasts within the lung parenchyma and then infiltrating into the alveoli. That is an entity we call organizing pneumonia. Okay, and second is there could be blood leaking from the capillaries into the alveoli, and that is what we call alveolar hemorrhage, or in this case diffuse alveolar hemorrhage. Then there are three abnormalities of lung growth or development that can produce consolidative patterns. They are pulmonary arteriovenous malformations, pulmonary hematomas, and type 2 congenital pulmonary airway malformations. So CPAM. So the thing is, these three entities, as I've shown with this point, the mark here, have very specific imaging findings and actually can be clearly demarcated from the other causes, and usually are asymptomatic. So that is why I'm trying to separate them from the rest. So essentially it is just organizing pneumonia and your alveolar hemorrhage. In the malignant side of things, obviously it is small cell lung cancer and non-small cell lung cancer. Even rarer forms of lung cancer are there, and they, however, don't normally present with a consolidation. They are more likely to present with a nodule. Okay. And then we have non-malignant infiltration of cells into the lung. So non-malignant infiltration into the lung could be induced by or could be targeting an infectious agent that has entered the lung, or it could be just directly due to some autoimmune or autoinflammatory process. So in case of the non-infectious infiltration, I like to divide the causes based on the type of cell that is infiltrating. So we know this. I'll use a mnemonic called gel. Okay, so that'll be granulomatous, or your macrophages slash dendritic cells. Okay, E would be eosinophilic infiltration, and L would be lymphocytic infiltration. It's quite self-explanatory. So in the eosinophilic infiltration, we have the entity chronic eosinophilic pneumonia, and we'll actually be going into the details of eosinophilic infiltration into the lungs in a subsequent talk on pulmonary eosinophilic disorders, and so we'll discuss it at that point. Then macrophage and dendritic cells I'll talk about in the next slide. So on the malignant side of things, we have lung metastasis. We have lymphoma, that is specific lymphoma, that is angioimmunoblastic T cell lymphoma. Then we have lymphomatoid granulomatosis, which is a lymphoproliferative disorder associated with an EBV infection, and we'll be getting into that. We'll be comparing it to lymphocytic ILDs in a subsequent talk on ILDs. Okay, so that's all. These are the malignant infiltrates. So in the next slides, I'll only be talking about non-malignant cellular infiltration into the lung. So non-malignant cellular infiltration into the lung, when it is macrophage slash dendritic cell mediated, could be Langerhans cell histiocytosis. Now, Langerhans cell histiocytosis may be a malignancy. It may not be. It may be a smoking-related ILD also, which is technically all. It is a lymphoproliferative, or it's a proliferative myeloproliferative disorder. Okay, usually due to your activating mutations in the RAS-RAF MEK-ERK pathway, most commonly the BRAF V600E mutations. We'll be getting into again the leads of this at a later date. Then we have an abnormal reaction pattern of the lung around the bronchi, excessive granuloma formation, which is called bronchocentric granulomatosis. Then we have, very importantly, sarcoidosis, which is a systemic autoimmune rheumatic disease. That is what SARD stands for. Okay, and we have granulomatosis with polyangiitis, with obviously is a vasculitis. So GPA and sarcoidosis. So lastly, non-malignant infiltration could be induced by an infection, and I use the mnemonic mean because these are all very mean infections. That is mycobacterial infection, endemic mycosis. E would stand for actinomycosis, and N would stand for nocardiosis. Okay, so to summarize, I would like to say that non-malignant cellular infiltration into the lung is something that shows up with chronic consolidation quite commonly, and those entities include your eosinophilic infiltration in the form of chronic eosinophilic pneumonia, macrophage dendritic cell infiltration in the form of Langerhans cell histiocytosis, your lymphomatoid granulomatosis, bronchocentric granulomatosis, and also your macrophage infiltration as a part of systemic autoimmune or disorder or vasculitis with excessive granulomatosis. So that obviously classically represents, without vasculitis it would be sarcoidosis, with vasculitis it would be GPA. And like I said, in situ proliferation of your pulmonary fibroblasts would result in infiltration of fibroblast balls into the alveoli, and that is organizing pneumonia. And finally, you could have displacement of the RBCs within the capillaries into the alveolar space, and that would be alveolar hemorrhage. So that is the diagnostic framework for evaluation of a chronic focal slash multifocal consolidation. Again, I prefer this term over the term non-resolving pneumonia, because non-resolving pneumonia tends to indicate that you can just close your eyes and you need not bother regarding the cause of an of a relatively shorter history of shortness of breath, and that can delay diagnosis. So there are subtle tells in history, in the exam, and even on imaging, that can give you an idea regarding the underlying etiology, as long as you know what you're looking for and what might be happening. So this is the diagnostic framework, and I'll see you in the next talk, and we'll be discussing imaging first, and then we'll be going into the details of the diagnostic evaluation of pulmonary edema, alveolar hemorrhage, lung, and eosinophilic disorders of the lung. Okay, so thank you, and I'll see you next time.